Good morning. My name is Jin-Hee Kim, and I am about 3 months into Aspen Institute. I help run public events and public engagement. When some of us think of AI, it can conjure up concern and skepticism, not to mention a little terror in what is still widely considered an unknown technology. We see movies showing the extreme uses of it, from terrifying creatures to apocalyptic worlds to strange societies of half-human, half-robot beings. But according to Harvard School for Public Health, there can be exponential improvements in healthcare when utilizing AI, including 50% projected reduction in treatment costs and when using AI for diagnoses, and a 40% projected improvement in healthcare outcomes. The incomparable Katie Couric is here with this esteemed panel to discuss how AI is transforming healthcare. But before we go, we'd like to show you a trailer from her extraordinary documentary, For Love and Life, No Ordinary Campaign. Thank you.
I remember someone told me, you have to meet this guy. He's going to change the world. And he did.
I met Brian on the 2008 campaign for Obama.
Sandra, what do you look for in a guy?
We've got it all, baby.
We found out Brian had ALS the day we came home from the hospital with our second daughter.
I had gone to a neurologist for what I thought was a standard checkup. The doctor said, on average, people live 6 months after they're diagnosed.
Every doctor we saw said the same thing. I'm sorry, but we can't help you.
The system is broken for this disease.
When you're told that the world you believed you were going to live in is no longer there, you have to either choose to curl up into a ball or act. So I turned to Sandra and said, I think I want to start an ALS nonprofit. And her response was, no.
And he ignored me, like he always does.
If you want to defeat ALS, you need everyone working together.
They took this extraordinary challenge and said, we're going to go out and make things happen.
If we're able to untangle ALS, we might be able to help others.
I am in awe of Brian Wallach. He wants to give back and take care of the next person that gets diagnosed.
I've never experienced a movement like this. It's changing history in front of our eyes.
Brian's ALS has accelerated a lot. We feel like we're running out of time.
Hey, Brian, we're gonna do this. There's always been a way.
This could actually work.
I don't think there's any test of the human spirit more telling than someone saying you don't have a long time to live and responding in this way.
I'm exhausted, but this is what I want to be doing.
I can't keep up.
You walk too slow.
Sandra and I have seen that trailer like 1,000 times, and we looked at each other and we said, we still love watching this. Hi, everyone. I'm so happy to see you all. If you've been to a lot of my panels, I hope you're not sick of me, and if you are, you can leave. Anyway, I am really excited to be here because this is something that is really near and dear to my heart. You know, I've had a lot of experience myself with the healthcare system in this country, starting with my husband's diagnosis of colorectal cancer in 1997 and his death, subsequent death 9 months later. My sister Emily's death from pancreatic cancer just a few years after Jay died, and she was just 54 at a rising star in the Democratic Party of Virginia. And then 2 years ago, I had firsthand experience with the healthcare system when I was diagnosed with breast cancer. Fortunately, it was stage 1A. And I'm doing well and had a lumpectomy and radiation. But I really saw firsthand the healthcare system, but really the healthcare system for a person of privilege, you know, and all I kept thinking was, what do people do who don't have money, who don't have good insurance, who don't have access to the best doctors? So this is something I really care deeply about, and I'm so glad that you all do as well. As Jen just mentioned, I am executive producer of the documentary for Love and Life, No Ordinary campaign. It premiered 1 month ago on Amazon Prime Video. Thank you, Amazon, for partnering with us. And it's really been an opportunity of a lifetime, because I can't tell you how much I love Sandra Apravaya and her husband, Brian Wallach. Brian couldn't be with us today. He's in Chicago. He's been traveling like a maniac, and he needs some rest. But we always joke that we're a throuple, and we're not really a throuple, but if I were in a throuple, it would be with these two. She and Brian, Sandra and Brian, are extraordinary, and if you haven't had a chance to watch this film, I really think you all would love it. It's so inspiring and uplifting in these dark times, and it shows the power of just, you know, what two people can do. And I think it makes us all feel like, you know, we can change the world in one way or another if we, you know, set our mind to it. So I'm so happy Sandra's here. Anyway, the reality is we'll all face health challenges. I didn't think, you know, I would deal with cancer 3 times in my lifetime. But whether it's getting sick ourselves or helping a loved one deal with an illness, and the emotional toll can be overwhelming, and the healthcare system, let's face it, is difficult, complex, and at times maddening, honestly. There's got to be a better way, and that's what we're here to discuss today. With the advent of innovative new technologies, as well as a deeper understanding of ways to center the patient's needs and experiences first, we have a real opportunity, I think, to create a smarter, more compassionate, and more extraordinary era of human health, and my fellow panelists agree. Joining us, of course, is the aforementioned Sandra Apravaya, who is, well, how do you want me to describe you? She is, she started I Am ALS. We know each other so well. And also a health...
I want to be described by the thruple, so said everything everyone
a healthcare startup called Synapticure, which is hard to say, by the way.
I know. I should have asked you before I named it.
You should have. Next time you start a company, please consult with me first. Also, Dr. Sunita, oh wait, this isn't in the right order, but that's okay because I have figured this out. Alex Reeves is the chief scientist of a company just announced this week. It's called Evolutionary Scale. Dr. Sunita Mishra, did I say it right, Sunita? Chief Medical Officer of Amazon Health Services and an internist, correct? And also Dan Sheeran, like Ed Sheeran, he told me, GM of Healthcare and Life Sciences at Amazon Web Services. Please, let's welcome these fine people. In all seriousness, it is so exciting. I think we are at such an incredible inflection point when it comes to medicine and patient care with AI and so many other forces at work. So I'm really excited to talk to you all about this. And Sandra, I thought I'd start with you. Tell us a little bit. Brian was diagnosed with ALS, and that was when he was 37. What year was that, Sandra?
2017.
2017. Can you talk about, Sandra and Brian were bringing their second daughter home from the hospital when Brian got the news that he had ALS. Can you, I don't think anyone can imagine how your world just cratered in a nanosecond. It was sort of like when I found out Jay had stage 4 colon cancer and everything just fell apart. What was it like for you guys navigating the healthcare system once Brian was diagnosed?
Yeah, it was so difficult, and it also speaks to how hard it is to access care. Brian went to this general neurologist appointment because he had a sense of weakness in his left hand, and he wasn't worried about the appointment. He thought it would be routine, and that's why he went on his own the day we came home from the hospital with our second daughter. And that general neurologist, who didn't know a lot about ALS, said to Brian in a room alone, "I think you have ALS." He did no diagnostic workup, and he said, "I think you have 6 months to live." That's what happens when you don't have access to subspecialty, high caliber, expert care. You get the wrong information, and you were not given the right options. And so then what we did was we scrambled to try to get seen by an ALS specialist, and we were told that the wait time was 4 to 6 months. And we were baffled. We were just told we have 6 months to live, and we can't get an appointment for 6 months. So what we did then was we called on our privilege. Our privilege is the only reason we got in. Brian and I met working on the Obama campaign. We worked in the Obama White House together. We have an incredible network and access, and it was that network that made phone calls and got us in. But for the lion's share of people living with these diseases, they do not have that access.
And all along the journey, from then to even today, Sandra, I mean, there is one challenge after another, after another, after another. Have there been instances, because you are fortunate to have this network and access, and quite frankly, the education and sophistication to navigate a healthcare system, even with a great network, because it's not easy. What were some of the other challenges, and were there moments where you thought, the healthcare system is actually really working?
Well, I would say that as a caregiver to a husband who started little by little, and for some people with this disease, it's very quick, lose his ability to move his arms, then his legs, then his fingers, the ability to talk. The burden on the caregiver is incredibly difficult. And so what I wish I had in a healthcare system is one that incentivized the kind of supports for caregivers that allow the caregiver to stay strong enough to be there for the patient. And I didn't find that kind of system. I had 7 binders that we flew around the country, and because none of the EHRs, none of the systems talk to each other, and so I'm like, oh, we got this test here, and I'm having to be this, as Katie knows, I'm very pushy, sometimes too pushy.
No, never too, well, sometimes.
Sometimes.
Yes, yeah.
But, I wish there was a version of care where, they said, let's take that burden off of you. Let's give you navigation support. Let's collate these medical records. Let's help you get access faster. And
Sunita, I know you've been a practicing primary care physician for 25 years. So you have firsthand experience with the patient and with what they have to deal with as a doctor. So why is the healthcare system such a nightmare for so many people?
That's a long answer, a very long answer to a short question. I will say that we've made the system very complicated. And what I've heard as a practicing physician helping my patients to navigate life-changing diagnoses, it's difficult for the patient and their family. It's also difficult for the provider. Just 2 days ago, I had a colleague reach out to me about a life-changing diagnosis that his daughter had and asked me for help because of his privilege. And it just makes me so angry that has to happen in our country. Like, everyone should feel like they have a doctor in their family. And I didn't know where to start as an insider. And so I'm trying to piece together information from multiple sources. And I think that's part of the challenge is that there's too many dots to connect. It's too difficult for the physicians who are trying to, all those binders that you were carrying around, for the doctor to have to ingest all that information and then give advice that is going to be really significant to the patient's health. That's challenging, and that's where we feel at Amazon that we have an opportunity to really make that experience different. Our mission really is to improve health outcomes in our country by making what should be easy in healthcare easier. It should be easy to get care when you need it. It should be easier to get the medications, and ultimately put the dots together so that people can get and stay healthy. And we believe that technology actually has a really strong part to play in that. We think that AI and all the new technology that's available to us can actually be the connective tissue so that the patients don't leave the office with a to-do list of having to find a specialist, find an appointment here and there. And we can actually create this sort of connected journey for people that's easier for both the providers and the patients.
Can we talk a little bit about the promise of electronic medical records? That was so exciting. And just from personal experience, I had an appointment with my oncologist, which is so kind of weird to say, but about sort of follow-up treatment for my breast cancer. And I had another appointment with another doctor, blah, 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 breast radiologist, et cetera, et cetera. And I had to kind of sit down and go through this. And I'm like, bro, although it was a female doctor. But I was like, hey, whatever happened to electronic medical records? Why aren't all reading from the same script? You know, I have this whole history, my family history I've gone through a million times, my internist, I've got some heart stuff I have to kind of be aware of, my cholesterol's high, but isn't this fascinating? I was like, what happened with electronic medical records? It's so annoying.
It's so annoying because every time you see a new provider, you have to tell your story again, and you want them to know you when you meet them.
And it takes up valuable time for both of us.
Absolutely, yes. And I think the promise of electronic records was, the promise was much bigger than what it actually delivered. I think that it's definitely improved the delivery system so that now you're not having to hunt through charts and read doctors' terrible handwriting. But there isn't a lot of interoperability between health records. And so if you even go from one hospital to another within the same city, sometimes they don't have the ability to connect to one another. And there's a lot of a lot of patient safety reasons why that's challenging.
What is it, like HIPAA stuff, or what is it?
Yeah, I mean, there's definitely HIPAA regulations that people are trying to adhere to, but there's also, you know, they're in the market trying to treat patients, and so there's a little bit of, you know, we want people in our ecosystem. Obviously, there's been a lot of great things that the government has done.
That's terrible, by the way. That doesn't really serve the patient, does it? If you can't go to a different hospital because that person is an expert in whatever you're dealing with?
Well, and there's been some steps that have helped with that. There have been health information exchanges that have been created so that people can actually pull records in from other systems. But it's still hard on the doctor who has to actually do that within a 15-minute time slot.
Right.
They have to go into another record, pull out the relevant information, bring it into their electronic record, and then digest it so that they can give you accurate advice. And so I think it can be a lot easier for providers. And again, we feel like AI has a really strong part to play there.
Well, tell me, because I don't understand how AI fits into electronic medical records.
Well, so I'll give you some examples. One is just most people have been to the doctor and you see that the doctor is buried in their screen and not oftentimes making eye contact with you. And so there's ways that, and Dan can actually talk about this, there's ways where we can actually ingest all of that audio information and put it into the records so that the doctor's focusing on you and your story and not inputting information into the computer.
Oh, interesting.
There's also technology available for us to be able to, you know, when I get records, they're like the folders that Sandra carried around, you know, several hundred pages of information that after hours I go through and try to put the relevant information into the EMR. There's now ways that we can actually ingest that information electronically and we can look at sort of the most important things and go back to look for information that needs to be clarified. And so I think that's going to take us a long way in what we call interoperability in healthcare, allowing doctors to have the information they need at the point of care, and patients not feeling like they have to tell their story over and over again.
Plus, and giving you more time with the patient because you're not dealing with all the, you know, reading all the reports and all that.
Yeah.
Well, what are other ways, Dan, that AI and AI technology is making the patient experience better?
Well, I wouldn't say there's a lot just yet, but we are optimistic that there are many advances coming, and they're very much the same things that we're talking about. The same challenges that Sunita was just describing are similar to the challenges that Sandra was describing from the perspective of the patient or the caregiver. And I'd really break it down into two main categories. The first is, going back to the binders example, I have different information from different healthcare providers, and the way that information was generated was not consistent. We have a very decentralized, I'm coming back to your electronic medical record system.
Go on.
Because it's such a decentralized system, everybody's rollout of the EMR, or the EHR, was largely up to them on things like standards and how they're going to describe a certain condition. And so even if you can get the data from each of those different providers, they're using different terminology sometimes. And so that's a good example of what AI can help with, because AI can go and we can train the models to know this term used by this provider actually means the same thing as this term used by this provider. And we're seeing a lot of progress in that area. That will benefit both providers and also the patients and families who are just trying to understand their own data that they've labored to get access to. The second thing that we can do And we're doing all of this today at AWS with a lot of partners who build on top of AWS and bring the patient and provider-facing solutions. The second thing we do, we're very active in, as Sunita described, is creating the technology that will free the provider from needing to be buried in the computer during the visit. And that breaks down into two parts. One, helping them prepare for the visit, and also helping the patient and the family prepare for the visit, because an AI model can do that same thing that I just described, summarize all of the history, combine it with the most recent information, the diagnostic, the test results that just came in, and summarize, here are the key things that for the patient to know, and here are the key things for the provider to know for the conversation we're about to have. And then to listen through the audio, Alexa-type devices that could be in the consult room itself, to listen to that conversation between the two of them and record everything, transcribe everything the doctor said into the EMR instead of the doctor needing to type.
And before an appointment, could a patient say, hey, I'm taking my aromatase inhibitors and they're turning me into the Mojave Desert, and she knows what I'm talking about, and or my joints hurt, and in other words, could that be put into the system? So before I even show up, you're like, oh, she's having some issues with this.
Yeah, that's a huge area of growth. We've actually already seen success with that on a discrete basis with individual systems, but just that the quality, the rapid advances in voice to text and understanding not just the words that somebody said, but the intent, what they were really trying to convey, is one of the big benefits of the large language models.
Now, I know that AWS has collaborated with something called Evolutionary Scale. And Evolutionary Scale has just announced the creation. This is when we all have to pay very close attention. So ESM3, which is a, quote, generative model for biology that has been trained on more computation than any other LLM, large language model, in that space, and can essentially write protein recipes with prompts. Good Lord. I am so sorry that this is your job, but what the hell does that mean? Go ahead. I told him you explain it for a 5th grader, or maybe even a 3rd grader.
I'll do my best.
Okay, thank you.
Yeah, so I'm really excited. So Tuesday, I guess, we launched the company, and more than that, the thing I'm most excited about is we launched this model, which is called ESM3. It's sort of the 3rd generation of language models that our team has developed. And normally you think of these language models as being language models of text, right? Human speech, and you think of chatbots and things like that. But so this is a language model which is actually it's trained on the language of biology, which is the original language. So it's trained on the code of life. And so if you think about that, for a moment, some 3.5 billion years ago, life emerged on Earth and invented DNA and proteins and RNA. And these are all sequences, and you can think about them as a text. And so everything that exists today, every living organism, and of course all of us are made up of these basic instructions and codes. And so our team had asked the question, and this, starting in 2019, basically, what would happen if instead of training one of these models to predict the next token on, text, what if we trained it on this code of life? And what we found is that these models, they really learn something deep about biology, and they really discover this very basic information about biology. And so we think that these can be very powerful tools to help people and to help scientists to really, make new discoveries about biology and ultimately program biology. And what we're so excited about with ESM3 is it's really the first model that we've created that can actually generate new proteins. So it's a tool, you can prompt it, and a scientist can prompt it, and it can create new biological molecules.
So this is really mostly for research purposes. In other words, because everybody's biology is different, right? That's why everyone, like cancer in different people, reacts differently depending on your biology. So are you saying, like, you don't need sort of to take blood from me to develop this protein. I mean, where do you get these proteins from? I don't get it, sorry. Are you working with me here, people? Okay.
I'll tell you, it's incredible. So, if you think about, the first gene sequencing project was the Human Genome Project. And it cost billions of dollars, to sequence the first human genome. But the cost of sequencing genes has gone down so much. And so we're not just talking about the human genes here. We're talking about kind of the genome of all of life. And so, there are scientists who go out and think about a handful of soil is full of microscopic life. And, you can gene sequence all of that and learn about all the proteins, all the biology that's present in that sample. And the worldwide scientific community has gone out and built these resources,
So you have scores of samples that you're getting this information from?
Yeah, billions of protein sequences from across the entire tree of life. So the depths of the ocean, the Amazon rainforest, microbes in the hand of, in a hand of soil, the human genome.
So that's where you've been able to identify these proteins?
And there are patterns across all of them.
Okay, so once you've identified them, what is the real world application? Once you're like, oh, I have this protein, that's so exciting. What do I do with it?
So it's really basic research. Proteins are the building blocks of life, and they're very important medicines. So everything from cancer therapies to weight loss drugs, all kinds of things, are made up of proteins. There are more, hundreds of proteins that have been approved as drugs. So that's one thing. But then if you really get to the molecular basis of disease, most of it at some level is caused by or involves proteins. And so, understanding them is really important.
Oh, so both drug therapies and understanding diseases are the most important applications. Dan, do you want to chime in on other applications?
Sure, I'll give you an example of things that we've talked about already, Katie. Most cancer treatments these days, not all, but most of the most widely used cancer treatments these days use a type of protein called antibodies. Most of us are now familiar with antibodies because of COVID, but also antibodies is the type of protein that is most commonly used for drugs such as Keytruda, which is the world's leading cancer drug. Now, oftentimes, you need to design not just a drug that's going to work for patients generally, but you're increasingly trying to design a drug that's going to work for a very specific mutation, sometimes an individual's mutation. And this is where the technology that Alex's team has developed comes in handy, because when he was saying a scientist can design the molecule, literally, it's the capacity to design an antibody that knows the specific mutation that you have and the specific gate or lock on your cells that the antibody needs to have a key for to unlock to then be able to get into your cell.
The checkpoint inhibitor, is that what you're referring to?
That's Keytruda is a good example of that. Yes, you got a gold star for that one.
Thank you. So you're talking about personalized medicine, drug development, but also further understanding the root of the disease itself.
That's
so because you have to kind of understand the disease to understand the therapy, right?
That's right.
So how soon is this? Obviously, you just announced this collaboration. When do you think we'll start seeing treatments develop from this whole mission?
Well, it takes a really long time to develop drugs. But I think what we're really excited about, and this partnership is about actually making this real. So this model, one of the things that we announced on Tuesday was actually creating a new fluorescent protein. So this is a protein that glows, and it's one of the most beautiful mechanisms
Did that really
in
make
nature.
you geek out?
It sure did. I think it made some other people geek out too.
Yeah.
But so this works. It can actually create proteins, and so we're working together to apply this to drug development now. And it'll take time before those therapies get into the clinic and are ultimately approved. It's a long process.
Katie, I think there's another way to look at the question. One is how much can we speed up the average time? I think many of you probably know it's about a decade from the time you have an initial start. It varies enormously, but at the low end, it's 7 years. It can be up to 18 years to develop a drug from inception to approval by the FDA and on the market. And we do think that we can speed up the early research phases for the reasons we're talking about. We don't know by how much, and it will vary, but it could be months, it could be years. I think the equally important point, though, is using the technology to better match drugs to the patients for whom it's going to work well.
Right. Well, personalized and targeted therapies are so important because I think this one size fits all and throwing something against the wall to see what will be effective is just so frustrating. You know,
That's
when
right.
my husband had chemotherapy, it was the same one that had been developed in the 1950s. It was 5-FU and leucovorin. And it was so frustrating to me. I was like, why can't there be a better way? But now, you know, I'm very involved in Stand Up to Cancer, and immunotherapeutic drugs are really actually showing so much promise, marshaling the power of your immune system to kill the cancer cells, and also targeted therapy. So is this both? Is this an immunotherapy, or I guess it depends on what the protein tells you, right?
That's right. I mean, I think it's really interesting to think about, you know, how those drugs came into being, right? Because, you know, first you had to discover the underlying mechanisms, and checkpoint inhibitors are such an interesting mechanism because, you know, cancer cells actually discover ways to evade the immune system.
They're the worst. They're so wily. They're
Yeah.
evil because they can kind of outwit their fiercest foe. They're like, oh, you think you got me? I'm going to figure out a workaround from whatever therapy you're throwing at me, right?
That's right.
Yeah, they figured that out. And then so scientists had to figure out how do they do that? And, you know, they have these receptors on the surface that do that. And so then you think
Or that
about,
block the therapy altogether, right?
yeah, I mean, there's many different ways that
Right.
they evade. But for the checkpoint inhibitors, you know, they basically block the ability of the immune system to recognize them.
Right.
But once you know how that works, you know the logic of that, you can make a drug that interrupts that.
Well, it's really exciting. And I want to spend a little more time talking about other ways AI can apply to improving our healthcare system. And Sunita, every year there are about 250,000 harmful medical diagnostic errors, many of which have devastating consequences, obviously. So how can AI allow doctors to make more accurate diagnoses?
Yeah, I think that that's a one really important area where we can leverage this technology. So it would be a dream to be able to have the ability to be able to have information so that you could personalize your treatment. Right now, most of what a doctor uses to make a diagnosis and to treat people is what they see in the four walls of their office. They don't have all the information about how you're eating, how you're exercising. They don't have the information about what zip code you live in. Those are all things that have such a big impact on health outcomes. And so it would be really amazing to be able to have all of that information synthesized so that when you're making the treatment or making the diagnosis, you are making it with a lot broader information as opposed to what you see in that 15-minute visit. On the point of diagnostic errors, I think that's another area where we can actually augment the reach of our clinicians by giving them more information about you know, what their differential diagnosis could be. So teeing up for them possibilities of what the syndrome of symptoms could be caused by. So that's one area.
So basically, the AI could say, here are the symptoms, here are a host of potential diagnoses, and maybe the doctor isn't thinking about one, right?
That's right.
Because they're human, and maybe they're, you know, headed down a path of a diagnosis, and they don't realize, so it could be something else altogether.
Yes, and in our training, we're taught to, you know, come up with a differential diagnosis of think about all the different things it could be, and then narrow down to the diagnosis based on the information that you receive. But in the way that we're practicing medicine today, in this sort of treadmill type atmosphere, sometimes doctors are going home and doing that research at home and then going back and calling patients to say, I think we need to add these other tests on to make sure that we're ruling out X, Y, or Z. And so I think giving doctors more information at the point of care will be incredibly valuable. The other big area where we see a lot of morbidity and mortality in our healthcare system is medical errors. So It's not just making the wrong diagnosis, but prescribing a medication that just gets dispensed inappropriately. And I think there are ways that we can use AI. We're actually using it today in Amazon Pharmacy to make sure that we're dispensing medications appropriately by using machine learning to make sure that we are adhering to the prescription that was given. And I think the same thing can happen in the doctor's office by making sure that we are crawling all of the documents that the doctor's creating and making sure that there aren't any errors that we're perpetuating. So I'm really excited about that.
Do you ever worry, I mean, obviously you're describing ways AI can be used as a tool. Do you ever worry that you're going to be replaced by AI?
I don't, because I think medicine is both art and science. And I think
I don't think you will either. I just want to ask.
No, I don't. And you know, a lot of other industries, they're talking about AI replacing people. I think in healthcare, it's actually going to make people want to go into medicine more because it's going to make their jobs more sustainable by giving them the tools that they need to be able to deliver care in the way that they were trained to do it. I ultimately believe that healthcare will become more human as a result of these tools.
You know, I think one interesting area, and I think we all talked about it, about, you know, having, medical biases are really a problem. I'm developing a documentary on the inequities of medical research for women versus men. You know, women weren't required to be in clinical trials until 1993, which is unconscionable. And really, women's bodies aren't really studied in medical school, right, Sunita?
We do study the female bodies in medical school.
But not very much, right?
I think it's in the research. Just as you mentioned, I think it was very recently that women were included. There's now a lot more intention going behind designing clinical studies so that we have a broader swath of our population represented. But
and not just gender, but race too.
That's right.
But I know that AI has the potential to either reduce or exacerbate and health inequities. And one example, women who visited emergency rooms with chest pain waited 29% longer than men to be evaluated for possible heart attacks in one recent study. You know, when I was diagnosed with breast cancer, my surgeon, who is African American, actually she's from the Caribbean, she told me that Black women have a 40% higher mortality rate from breast cancer than white women, for a whole host of reasons, not just access, but dense breast. Don't get me started on dense breast. If anyone wants to talk to me, call me, because I'll tell you all about dense breast. But I guess the question is, how can AI level the playing field for people who honestly have been kind of ignored by the medical establishment? Who wants to take that?
I can start.
Go ahead.
Why don't you start?
Well, one of the things it can do is take less of the, I don't want to, I agree with everything Sunita said, and I don't think providers are going away at all, but I do think there's a range of decisions that we're putting onto providers that they are ill-equipped to make. And so this is I want to connect this with the point that Alex made about the rapidly declining costs of genetic sequencing. Everybody who has cancer should have their cancer genetically sequenced, period. There is so much evidence this connects to the misdiagnosis point. It looks like it's this type of cancer, but it's actually not, and you're not going to know unless you actually get that tumor sequenced. And our hope is that with this rapid decline in costs, everyone's going to actually, we believe the day is coming, and we certainly hope it is, where you get sequenced every year as part of your annual physical. Mm-hmm. Now I want to connect that to your question. If that happens, and you have the systems ready to analyze that, then the provider is presented with very compelling information that they are really going to have to act on, rather than relying on their own, let's face it, biases, that are, I think, at the root of the problem that you're describing.
And let me read this quote from Forbes, which I think is interesting, because I think what we're saying is doctors are human, right? And Forbes writes, a clinical-ready AI chatbot tasked with producing a clinical intake report for a doctor prior to a patient visit won't be influenced by insomnia, burnout, or hunger when taking down a patient's symptoms, nor will he be prejudiced, or she really, nor will she be prejudiced against obese patients or fail to take women's physical symptoms as seriously as men's. So basically you're saying it reduces or eliminates bias in many cases, which is
It's a more
good
elegant way of
thing.
saying what I was trying to say.
Yeah, no. Well, it was written in Forbes, so I can't. But are you, on the other hand, listen, there's been a lot of stuff written about AI and implicit bias in the large language models and the way the data was amassed, mostly by white dudes in Silicon Valley, right? So can you think of ways AI might exacerbate biases in the healthcare system?
Sure. You want to take this one, Sunita?
I mean, I think it certainly can exacerbate, but I feel like we're in a much different place than we were back in the 90s, where we weren't even aware of our own biases. And I think that because we have this awareness now, we're very intentional about how we're building our foundational models, making sure that there isn't bias that's in there. It's one of our tenets to make sure that as we're building, we have that in mind. You add to that.
And fortunately, AI can be a tool in preventing AI from having these biases. We have very sophisticated tools that we're developing all the time.
So it can basically self-police.
Yeah, or you can build models whose job is to look at the other model and try to monitor when there's what we call drift in the model that may be a source of the data that was originally trained on is not consistent with the data that's being used in the field as that model is out there. So it's an excellent question. It's something that at Amazon we put an enormous amount of time into. The general category is called responsible AI. And not only do we build this into our own AI services, but we are vigilant about this in terms of whom we partner with. The third-party AI providers like Alex's company, like Anthropic, which is deeply committed to responsible AI, that we bring into AWS and make available to our customers. But ultimately, this has to be a collaboration with the providers who provide the data. It comes back to your earlier point about if the people running the health systems aren't also thinking about this, that's where the data is originating that these models are trained on. So it needs to be a partnership between technology companies and the health system to be looking very objectively and in a very systematic way about what is the source of the data that we're training
And you think
the models
doctors will adapt? Because doctors can be kind of stubborn and set in their ways, right?
No,
I mean, is this going to be taught in medical schools? Is it going to be integrated so that people won't have to make this leap and this adjustment where they're used to doing something for years and have to suddenly pivot? Do you think, Sunita?
I think it will be, and I think that we're going to be able to use some of this technology to train doctors.
Yeah.
And so I'm really hopeful that we are going to be able to eliminate some of the biases that have been in our system for hundreds of years.
Right. Well, Sandra, don't worry, I haven't forgotten about you.
Don't worry.
After all the work that you and Brian did in patient advocacy with IMALS, which really, well, you want to explain quickly what IMALS is?
Yeah, absolutely. So when we first got diagnosed, obviously after being very devastated by the news, but once we got a real appointment where we got real guidance that our prognosis was not 6 months, it was 2 to 5 years, obviously not a great prognosis for anyone in their 30s starting their family, but certainly better than 6 months. Brian and I come from public service, and we knew we're going to be able to survive longer if we're mentally in the right place and we feel agency by taking on a bigger fight here. And so we know that's going to be good for us too, to do that. And so we jumped in as advocates, and over the course of 7 years since we were diagnosed and we started to build and drive forward this patient movement, we have increased federal funding for ALS by now over $1 billion. And that's the work that we have largely driven forward. Yeah. And so that was our focus. How do we get patients access to these therapies and sort of take this fight on from a government perspective at the outset?
And so, of course, I know very well your extraordinary work, but tell me how Synapticure, the poorly named Synapticure.
I know. We can talk later. It's not too late to rebrand.
No, but what does that do that your other efforts don't? I mean, where does that pick up?
Yeah, absolutely. I mean, just coming back to how I sort of shared our story to begin with, there is a real shortage of physicians who specialize in Alzheimer's, Parkinson's, and ALS. So what I just told you all about my and Brian's experience is common among all of these neurodegenerative diseases. And so for ALS, we were told we had to wait 4 months, 6 months to get an appointment. You know, the top memory care clinics and the Alzheimer's and related dementia space, you're looking at 8 months, 9 months, 10 months to see a specialist. And the problem's only going to be exacerbated because of the aging population and the growing rate of these diseases. And you guys all know this, like, it's not a sexy field. People are not signing up for neurodegenerative disease specialist roles. And so how are we going to democratize the care with the physicians we have? How do we stretch their access? And I do want to speak for, in a moment about how I really do believe in AI's power to contribute to that, and I'll build on that in a moment. But we started a company that provides virtual care for all of these diseases in all 50 states by basically taking the physicians who do specialize and making them available via telehealth. And that allowed them to reach the nooks and crannies of the country that are underserved, where people don't get access, and we're able to really maximize the sort of availability of the doctors that do exist.
Which is incredible, but you also have something called Guide, and it's something that the Centers for Medicaid and Medicare and Medicaid services has that you're joining with
Yes.
them. And it's really revolutionizing the way families are being helped who have a whole host of neurodegenerative diseases. Explain what that is.
Yeah, so, we started with this advocacy background. We started up a healthcare company focused on access. And now this is the merging of our two lives. And I'm a big fan of government. Sorry, everybody. But they're doing really good things. So one very exciting new development is that CMS, which oversees Medicare, is now, in a matter of days, July 1st, launching a new program to try to transform the way this country approaches Alzheimer's and related dementia care. And what it's going to do, it's going to reimburse physicians and nurses differently to incentivize them to spend more time on the things that patients and caregivers need more help with. So it's hugely exciting. It is, I think, an opportunity to prove on a national level in this disease state, which I hope we replicate in others, that supporting the caregiver is going to pay dividends. If the caregiver is strong, your patient, the spouse, the parent, is going to be in the home longer, going to go into a long-term care facility much further down the road. You're going to reduce hospitalizations because the caregiver is going to have the support they need. So all of these things are super exciting, and now it's a really special moment that the healthcare company we started and run, which has a name that needs revisions, that we are now partnered with CMS to support dementia care in all 50 states through this really caregiver-centric model.
That's wonderful. And could that be expanded to even beyond neurodegenerative diseases?
Yeah, absolutely. I think what we're going to see is CMS, as CMS does, is going to show cost savings.
Right.
They're going to be like, well, look, reduce hospitalizations, long-term care facility reduction of costs. Like, it's all going to pay out, and it's going to hopefully incentivize commercial payers. And that's going to be amazing. Because right now, Brian's caregiving needs, just to give you a sense of it, Brian and I pay $300,000 out of pocket every year because my husband is totally paralyzed and he can't talk and he can't move, and I cannot move him. I am not strong enough. I cannot be there 24/7. I cannot feed him. I cannot bathe him. I cannot take him to the bathroom. And what family can afford that? And commercial insurance and even Medicare today is not covering it. So again, only through privilege can I leave my husband in Chicago and be here at Aspen to even tell you that story? Because everybody else in my situation is imprisoned in their home. If somebody in your family gets diagnosed with one of these diseases, your own life is over. And I am not exaggerating.
And one of the many things that Brian and Sandra have done, for example, they work with other ALS patients to get Social Security disability benefits handed out to ALS patients immediately. Prior to their advocacy, a patient had to wait 6 months to start getting that financial support, which, as we know, for many ALS patients, is a lifetime, literally. Before we go, I just wanted to ask you a couple quick questions. I'm not going to open it to the audience. I hope you guys are okay with that. Sorry, we don't have time. And I'm sure you have great questions, but I have better ones. So I want to ask you about the cost of drugs. You know, I thought it was really interesting. According to the New York Times, the total cost of developing a drug averages out at about $1 billion, takes 10 to 15 years, as you mentioned. And not to mention the fact that 90% of them fail in human clinical trials. So, Alexander, I'm curious if this collaboration is going to lower the price of drugs, which is really actually, I mean, understandable on some levels because research and development is so expensive. But on the other hand, it's kind of criminal for the average patient. So, do you think this will lower drug prices ultimately?
Well, we hope so. I mean, I think, you know, drug development is costly because it's so hard, and, you know, one out of 10 drugs that goes into clinical trials is going to succeed. And so, you know, you think about it, it's just this painstaking process of trial and error. And, you know, the big reason for that is just that we really don't understand the basis of disease as well as we need to understand it. So,
so is that a yes?
These are incredibly hard problems, and they will require incredibly hard work from, you know, the entire scientific community, people like Sandra, people like AWS.
I don't want to speak for Alex, but I'll give you a yes.
You will.
I'll give you a yes for two reasons. What Alex said, if we can, the reason it's $1 billion, the successful drug often did not cost $1 billion. Actually, some people think it's $2.5 billion per drug, but you're covering the cost of all the losers. So if you can rapidly increase the success rate,
or winnow down the possibilities, right?
Well, then you're not having to cover as many losses, and so the average cost should go down. But the other big opportunity that AI enables is to recruit the right patients for the trial. Once we have a better understanding of the mechanism of the disease, and we know, well, if they don't have this genetic mutation, then they shouldn't even be included in the trial. We're going to have more successful trials that will enroll faster and they will complete faster. 40% of trials don't even start because they can't recruit the required minimum number of patients to do the trial.
Well, how is AI going to get more people to participate in clinical trials? Because that is such a huge problem, especially people of color.
If you don't, that's a very complex problem, but one thing that AI can do is, if we have this richer understanding of the disease that Alex has been talking about, you actually don't need to enroll as many people. So if you reduce the number of people that you need for a phase 3 clinical trial, then even though you have certain populations that are not enrolling at rates that are proportionate to the representation of the population, at an absolute basis, there are far fewer of those folks you need to find for each of those populations.
Well, it is a brave new world, but a very exciting one too, and a very complicated one. Alex, you did an excellent job of boiling it down for all of us. Thank you all so much, Sandra, Alex, and you. Thank you.
you.